Welcome back. Hope you've had a quick break, chance to stretch your legs, grab a coffee. We're moving straight on to a session which is mainly devoted to oncology, some very important topics, women with postmenopausal bleeding and evaluating endometrial cancer, and also evaluating cervical cancer using ultrasound, really important topic, especially, for example, if you don't have cross-sectional imaging and in countries where perhaps there's not so much screening and the prevalence of cervical cancer is high. So our first speaker, Thierry van den Bosch, I'm hoping he's going to be able to join us in person now, but if he's not going to be able to join us straight after his talk, he will be available later in this session to answer questions. And he's going to talk about evaluating the endometrium women with bleeding, but also talking about how to use ultrasound to evaluate women once you have a diagnosis of cancer. So I'm going to hand over to Thierry.
Hello. I will say some words on the ultrasound features of the endometrium in women with postmenopausal bleeding and in women with endometrial cancer. I have no conflicts of interest besides that I'm kind of a ultrasound nerd. In 2010, we published a paper, consensus paper, on how to describe the endometrium using ultrasound. And we can say that before 2010, the main focus of the ultrasound evaluation of the endometrium was the measurement of the endometrial thickness. And indeed, the endometrial thickness is important. And it is so that the thinner the endometrium is, the less likely it is that there is some malignancy inside the endometrium. That was so in 2010, that stands still today. So and the cutoff for the safe cutoff is somewhere between 3 and 5 millimeters. But just measuring the endometrial thickness is not enough. You can see much more using ultrasound. So the qualitative assessment of the endometrium is important. And if you look at the endometrium, you can look at the uniformity of the echogenicity, and the echogenicity might be uniform. Typically in the first part of the cycle, you see a 3-layer pattern, and in the second part of the cycle, you see a hyperechogenic homogeneous pattern. And after menopause, the endometrium is thin and echogenous in most cases. Sometimes the endometrium might be non-uniform because the echogenicity is disturbed by the presence of cystic areas within the endometrium, or sometimes because the echogenicity of the background endometrium is inhomogeneous. And sometimes you have both the cystic areas and inhomogeneous background, making that the echogenicity is non-uniform. It's important to look at the midline of the endometrium. If the midline is linear, or is it non-linear, irregular, or not defined, this is important, as we will see in a moment. It is also important to look at the junction between the endometrium and the myometrium, and to look if it is irregular or irregular or interrupted, or sometimes you don't see where the endometrium starts or ends. That's important information. And the use of color Doppler is really a part of the routine ultrasound evaluation of the endometrium. And when you switch on the color, you can either see that there is no color inside the endometrium, or there might be color signals inside the endometrium, and you can score the color between 1 and 4, 1 meaning no color and 4 meaning abundant color. But you can see even more details than color or no color. You can look at the vascular pattern of the vessels, and you might have single dominant vessels with or without branching. You may see multiple vessels from focal origin or from multifocal origin. Sometimes you see some scattered vessels, and sometimes you see a circle flow, and that's important because it gives you a hint as to the presence of, for instance, a polyp, cancer, or a fibroid. So that's in 2010, and it's one thing to say that's the way to do it, but it's another thing to prove that it matters. And that's what we did in the first AITA study, looking at about 3,000 patients with abnormal uterine bleeding, and to look at the ultrasound features of the different histological endpoints between cancer patients, polyps, or atrophy, and so on. And so we looked at the results, and we looked at the different histological endpoint, and we tried to describe like a facial composite of the different histological endpoints. For instance, atrophy was something we saw quite often in postmenopausal women with abnormal bleeding. The most common pathology we saw with postmenopausal bleeding was the presence of endometrial polyps, and of course, in quite some patients with postmenopausal bleeding, you also find endometrial cancer. So, what are the typical features? Well, for instance, in endometrial atrophy, you expect the endometrium to be thin, and indeed it was so in our study. And if you look at the other features, you see that endometrial atrophy is associated with an undefined midline. It's too thin to have a midline. You don't see the midline. The endometrial myometrial junction is often regular, and if you switch on the color, in the large majority of cases, you will not see any signal, any color signal. So atrophy is associated with a thin endometrium, regular outline, and no color. Okay. In endometrial polyps, you see that the in premenopausal patients, you see the bright edge and a single dominant vessel with or without branching. You also see that in postmenopausal patients, but to a lesser extent, the bright edges is less common in postmenopausal women. But what's quite common is to see a non-uniform echogenicity due to the presence of regular cysts. That's quite striking results of our study. And if we look at endometrial cancer, as we knew, cancer is associated with a thickened endometrium, and indeed, well, half of the patients were between 11 and 26 millimeters in thickness. We had patients with thinner endometria, and also a patient with thicker, but let's say the median was between 11 and 26 millimeters. And if you look at the features, you see that cancer is typically non-uniform, so heterogeneous echogenicity, without cysts or with irregular cysts. You don't see the midline because there is tumor. You don't see the midline. of the endometrium, and if you switch on the color, you see multiple vessels from focal or multifocal origin, and the color score is high. So cancer, thick, inhomogeneous, and a lot of color. But we also looked in this study what is reassuring as to the absence of cancer, and the reassuring features were first thin endometrium. We did not see any cancer below 3 millimeters. A 3-layer type of endometrium is also reassuring. If you see the midline, and you see it's a linear midline, that's also very reassuring. And if you see only one single vessel without branching, that's also rarely a cancer. So these are reassuring features. We also assessed fluid installation sonography in our study. Most patients had fluid installation, so we could comment on that and see what the data were. And here we saw that if you do a fluid installation and you see a polyp typically has a regular outline. That's very important, a regular outline of the lesion. And if you switch on the color, typical for a polyp is a single vessel, with or without branching, a single vessel. So, and after menopause, we also saw with fluid installation that in the polyp, we often, in half of the patient, we see a regular cyst inside the polyp. So that's the typical image of a polyp, as opposed to a cancer. If you have a cancer, typically on fluid installation, you see that the lesion is irregular lesion, and if you switch on the color, you see multiple vessels from focal or multifocal origin, and a lot of color, a high color score. So that's the typical image of cancer. And in another study led by Elisabeth Epstein from Stockholm in Sweden, we looked at the features of cases with cancer, with proven cancer on biopsy, and we looked at those patients and we looked what the features were as to the staging of the cancer. So to see if, looking at the ultrasound features, we could see who is at high risk for a more higher stage or nodal involvement. The study involved more than 1,500 patients, and to summarize, what is a high-risk patient? Well, a high-risk patient for high stage or nodal involvement is a high-risk patient has the echogenicity is often hypoechogenic or had mixed echogenicity, as opposed to low-risk, well-differentiated cancer who are often hyperechogenic. If you look at the size, high-risk cancers are often larger, as you could expect. And if you look at the junctional zone in high-risk patient is often irregular or even not visible because there is invasion of the myometrium, so you don't see the junctional zone. And the tumor-free myometrium in high-risk patient is often thin because there is invasion, and you see that there is only a little bit of myometrium left. And if you switch on the color, high-risk cancers often have a high perfusion. So that's, in a nutshell, the features of high versus low-risk patients as to staging. Well, we can say that with ultrasound, in cancer patients, we are quite good in predicting the size and the invasion of the myometrium or the cervix. So the prediction of myometrium and cervical invasion at ultrasound is at least as good as the evaluation during a perioperative operation on frozen section, or even compared with MRI. So that's certainly a good and a cheap tool to assess myometrium cervical invasion. And to conclude about the endometrial ultrasound, we in the future, or well, the future is now, but we moved from the evaluation of the thickness of the endometrium, but now using also the other features, we can, looking at the patients and looking at her characteristics and the ultrasound characteristic, differentiate between those patients who has a thin atrophy, who does not need any further investigation, those who have a polyp or intracavitary fibroid who might benefit from operative hysteroscopy, and those with cancer who need urgent treatment, and those with more hyperplasia who might benefit from hormonal therapy, for instance. So Laura Reynolds from our group tried to design a model, a statistical model, to predict those histological endpoint, and doing so to help us in the management of the patients. And she based on two demographic features, age and BMI, and sonographic features being endometrial thickness, echogenicity, the cystic areas, the presence of a bright edge, the color Doppler score, and the presence of a single dominant vessel. She could design a quite performant statistical predictive tool to predict those who will have atrophy, those who will have a focal lesion in the cavity, those who have most probably cancer, and those who have other dysfunctional pathologies. And I think this may prove to be of use in the management of patient and in the triage of patient, and especially to see who are those at high risk for cancer, or those who have no cancer and should go home and do not need any other investigation. So that's in a nutshell what ultrasound can offer you in the evaluation of women with postmenopausal bleeding. Thank you very much.
So Thierry, thanks very much. I think Thierry's going to come back and be available for any comments and questions later. However, I would like to welcome Ahmed Sayasna, my co-chair. Ahmed, lovely to see you. For those who don't know Ahmed, he is has a foot in both camps, being a proper doctor who's a gynecological oncology surgeon at Guy's and St Thomas's. And associate professor at King's, but also, of course, also did his thesis in gynecological scanning as well. So, you know, knows the whole topic. Ahmed, welcome. Good to see you. How are you?
Thank you so much, Prof. Bourne. How are you? I'm all fine. Thank you for that.
Yeah, not bad. In terms of using ultrasound with in endometrial cancer. I mean, is this something that you know, in your practice? How much do you use ultrasound or cross-sectional imaging, or where do you position ultrasound in patients who've actually got, you know, a diagnosis of endometrial cancer?
I think certainly in the first instance for the diagnosis, I think quite important to make the first stop. Later on for the staging, current practice, we still do, unfortunately, use the MRI to stage the endometrial cancer. I'm trying to move away from that and just do something like a fusion imaging, to use both MRI and ultrasound scan, because I still find it useful, especially when MRI is not available or contraindication, or during surgery when we try to do some staging for a patient as well in theatre, which sometimes happen. So I think, yes, we have to move more for ultrasound scan, but unfortunately the current practice is more MRI for staging.
So it's a work in progress, I guess.
Yeah.
But I suppose if you're in a kind of what you might call sort of a low resource setting, I think that's obviously a lot of people.
Oh, definitely.
Then you know, if you can get the training, then you do feel this is an appropriate tool, basically, to
absolutely.
Which will change clinical management. Is that fair comment?
Absolutely.
I'm sorry to well, you're meant to be chairing. I'm kind of chatting to you about Thierry's talk, so my apologies. So as if I'm putting you on the spot when you shouldn't be. I was interested because Thierry was talking about obviously AITA, and I think a lot of what he was saying was fairly clear. But I don't think people are always so clear when it comes to patients on tamoxifen, for example. And they can create particular problems, I think, where, you know, obviously you get these quite, you know, fairly typical changes. And I think in these cases it's quite difficult, isn't it? Because endometrial biopsy, you don't kind of get tissue either very much. I mean, how do you manage these patients when they turn up with a thick cystic looking appearance in the uterus, and they've had a bit of bleeding, for example. What's your management of those patients?
I mean, we do have a very low threshold to do outpatient hysteroscopy, which we developed lots of technique to increase the success rate of this to be done as a one-stop clinic. So the patient will have the scan on the same bed. There will be another hysteroscopy machine, which we use the alpha scope or one of these tiny scopes to get in. And many times we use the ultrasound scan as well. If it is a steno cervix, we still can use the scan as a TR or transrectal to see the pathway of the scope. So we develop lots of skills to be able to do the diagnosis in one go, but we certainly will need to move to another diagnostic tool, which is hysteroscopy, if we can.
on whether on sequential therapy or continuous combined or something, because I mean the endometrium basically should still look thin and atrophic, shouldn't it? Or do you kind of approach it slightly differently?
Yeah, I mean, we tried, but unfortunately there is nothing in the guidelines or in the literature to help us what's the right cutoff for these HRT patients. So we're a bit, you know, confused. It's easier for the postmenopausal one, but when they are on HRT, we take this on board, and we know that it can change your cutoff, it can change the information. But the problem is we want the answer, and we want to tell the patient, look, everything's fine, and you don't need to worry about cancer. And that's why we have the very low threshold for hysteroscopy for these patients, regardless of the cutoff. We go by symptoms and by ultrasound scan. So because it's easy and just next to the machine, we have the hysteroscopy, and that's why we just say, okay, look, we're not changing anything. We have to do the hysteroscopy, and we just do it, and it takes extra 10-15 minutes. That's all. So maybe in our setting, maybe you're right. Maybe we have to do something about the cutoff, take on board. But what's the right cutoff for HRT patients? It's difficult.
Yeah, I always take the view that, you know, continuous combined, it kind of burns the endometrium out. It should be pretty thin anyway. And I think,
yeah.
And I think sometimes you can look at endometrium as in a dynamic way. You know, and you know, once they've had a bleed, for example, bring them back. You can look like the ovary. I want to come back to you on one question in the chat, if I may, Ahmed, because it's something which I think you'll find of interest. I mean, it's around, and I presume they mean progesterone coil. Predict the use of the progesterone coil on patients who don't actually or have not had postmenopausal bleeding or endometrial cancer in the future. But I mean, let's just rephrase the question. Do you see the Mirena coil as a useful tool? So I know that Emma Crosby's done some work on using the Mirena coil in patients at high risk of endometrial cancer for preventative reasons. Do you see patients with Mirena coil or using it as a preventative tool, or you know its role, for example, in you know atypia or low-grade cancer sometimes?
Oh, definitely. Yeah, I mean, we use it. There are two ways: the preventative tool and as well therapeutic tool. So for preventative tool, it's very well known for the HRT patients, for example. It's very good method to prevent from the side effects of the estrogen. Yes, patients with high risk like polycystic ovaries, high BMI, as you know, the unopposed estrogen, definitely it has a preventative tool, but as well as therapeutic with hyperplasia, whether simple or complex, or even cancer early stage. Mirena is being used widely for treatment for fertility preserving purposes. Yeah.
Come back.